Consultant cardiologist in Apollo Hospital. Today is 16th of March. We have done an important angioplasty. Patient was referred to us as a case of anesthesia. Troponin was high. ECG was there, was changes, but the patient presented with acute LVF. Sometimes acute LVF is the first presentation of the patient, and patient did not have any history of chest pain. And myself with Shiji as a nurse, Dr. Vivek Gupta, and Mr. Basant, who is a senior technician in Apollo Hospital. This is Apollo Hospital, New Delhi. So we did an angiography after control of the LVF. The patient LVF was partially controlled when the patient came to us. So we did further Lasix infusion and we made a negative, and the patient chest crepes completely disappeared. Patient became almost normal. Echo showed ALV EF of 40%. The patient had suffered acute coronary injury because troponin was high. And therefore now we have to see the angiographic shot. We did the angiographic shot and we took the first shot. As you can see, the patient has a calcific vessel all through. The arteries are smaller in size. He is a diabetic. And you can see there's a tight lesion in the OM2 or OM3 branch, which is almost discrete. And you can see the mid LAT is having a more than 70%, 80% stenosis after the diagonal one. We did the right coronary artery, and right coronary artery, this is further to convince ourselves that lesion was there. Right coronary artery, you can see there is no lesion as such, only plaquing is concerned, but at the place of origin of the sinus artery, we did further pulled out and we found that there was a lesion which is about 50 to 60%, and we took further decision whether should we do angioplasty of right coronary artery, but in diastole it is filling quite well and there is only 50% stenosis. Come back to me. So we decided with the family that we should do angioplasty of the LAD and of course the OM branch which is having a tight stenosis. We debated among ourselves whether we should do right coronary artery, but in best of the views it showed not more than 50 to 60%. And the patient had a calcific artery. So considering sometimes you can debate between an optimal revascularization and a complete revascularization, I think we have opted out not to do RCA because the lesion was not tight. So we have done a quick angioplasty, and you can see we have done a quick angioplasty, and now you show the pictures. We have taken a shot so that we can measure it without doing KCA. This is a 30mm segment, and to measure it, that this is the length of the lesion. We were quite convinced that 28mm length will be okay. And we did a pre-dilatation with a 2mm balloon, and it's a calcific lesion. I was quite a little skeptical whether the stent will go or not. We kept on dilating very well with 2mm balloon. Always do a good good pre-dilatation. That's very important for the success of the angioplasty. If you do a good pre-dilatation, and therefore the stent delivery becomes easy. You can see there are a lot of calcium in the proximal LAD, but this is the Pronova XR stent, which went with little difficulty, but finally it went there. Not a major difficulty. I was expecting more difficulty, but my technician, Mr. Basant, was more optimistic. He said no, it will go easily. We managed to do with a 2.5mm stent deployed at 14 atmospheres, 2.75 into 28, Pronova XR, and good. Finally, there is a good result. There is a mild pinching of diagonal, which is of no concern. We went to the with the same wire we had done a stenting. This is a pretty direct stenting. As you can notice, there is a calcium, and also the proximal circumflex is having a lesion, which is about 50%. And I was again skeptical, but my technician was more confident, and we finally went there with the easy. Of course, a small push was required, and we have done with 2.5mm into 12mm stent of Pronova XR. The final result is perfect. You can show. We always take the stent boost. Show the stent boost up. We always do the stent boost, which is the part of the cath lab, and to check whether the stent is fully deployed or not. And this is the final result. Come down. This is the final result after pulling the wire. This is the final result, and we have pulled the wire out, and this is the final result. As you can see, a fully dilated OM branch. And of course, we were thinking whether should we do a stenting of the proximal circumflex, but it was about 50 to 60%. But the stent went very well. That showed that this was not actually tight. If the stent without pre-dilatation of the proximal segment went into the distal part of the circumflex, into the OM branch, it showed that the lesion is not tight in the proximal part. So myself, Dr. Vivek Gupta, once again emphasizing that do the optimum. Do not try to do too much of stenting. If the lesion was in RCA was only 50%, don't try to change the stent unnecessarily. Of course, it's better to always check with the angio. Patient was not on statins earlier. We will do optimal medical treatment, and when we can see the check after 6 months whether the stent of the RCA or proximal circumflex is required or not. So our best is to reduce the number of stents, do the maximum and most optimal number of stents should be used. wherever there is tight lesion, and unnecessary stenting may be a problem. Don't try to overuse it. Thank you very much. I'm Dr. Vivek Gupta from Apollo Hospital. Shiji Basant is very important. Technicians are very important for us. They are the backbone of the cath lab because they keep on guiding us, guiding whether we should do or not. We should do. It's always a good discussion. There is no other person who can be, because there's only with single operator, and therefore it's importance of the technician. A trained technician is very important for all the hospitals. I would always request that all the new hospitals which are coming up all over India, they should have the technician quality, and the training of the technician is very, very important. Thank you very much, Dr. Vivek Gupta from Apollo Hospital, India.
Thank you.